Most of the people have low confrontation, don't do prepays, and they stop doing prepays. That alone creates huge problems with patient retention and missed appointments. That creates a huge problem. And then if you got low confrontation, you're afraid to ask for referrals. So now you got a new patient problem, and now you have a patient retention problem. And let's say you know how to do it, but now you just don't have confrontation enough to do it. And remember, what increases confrontation? Conviction. That's why I spent so much time with conviction with my doctors. I didn't just have them, oh, go watch this video. That's not how it worked. They had to read it all, they had to know it all. And then I drove it home by doing case examples. We would take a case, we'd go into all the ball markers, we'd go to the mechanism of injury, the ball markers, and go, okay, what are all the diagnoses? And I'd literally do case examples with the new doctors training. Okay, what are all the potential diagnoses based on that mechanism of injury and the patient's ball markers? So we get all those. Then we go, okay, that's the diagnosis. Now what's the therapeutic protocol? Based on those ball markers, what therapies do? Well, that's based on the science of the 3 phases of healing. So where do you always have to start? You always have to start with pain and inflammation. You can't be doing strengthening and stretching when they don't even have full mobility and they have pain and restrictions. You can't. So we have to start with, okay, where are we at with pain and inflammation and general gross range of motion relative to pain and restrictions? So that's always the therapeutic protocol to begin with. Then you go, okay, what's the therapeutic protocol for pain and restrictions? Well, what therapies are you using? Do you know what therapies you're using and how it affects that tissue physiologically? Well, all my doctors had to know that. It's not like, oh, we're going to do muscle stim, but I don't know how it works. Oh, we're going to do laser, but I don't know how it works. I don't know the physiology of how it works. That's not acceptable. That's actually totally unacceptable. So and again, I'm talking about increasing conviction. So we got the mechanism of injury, we got the bowel markers, we got the diagnosis. We're going to go, okay, what's the therapeutic protocol? Well, we know we need to start with the inflammatory phase, start reducing the pain and inflammation. Okay, so what therapies are we going to use to start decreasing our pain and inflammation? Now, in my office, there's all kinds of things you can do. There's 1,001. Okay. In my office, we used, for pain and inflammation, we did, of course, the chiropractic adjustment helps with pain based on the gait theory. Also with passive mobility. When somebody was real acute, I would, sometimes I would just work on passive mobility. But that's the gait theory again, and it acts as a mechanical pump for inflammation when you do passive motion. See? And same with, they would do the ice pack at home. We're not doing anything in the office. You don't get paid for it. That's not real smart as a business person. So we typically, in the first few days, we have do the ice pack at home. We do chiropractic, and we do typically muscle stim or a TENS unit, something like that, to help with pain. And typically that's put on, when you use stim, that's typically put on tetanized, not pulsed. Pulsed is used for decreasing muscle spasms. Tetanized setting is above threshold. That works on the gait theory to help block pain. That's how that works. So that's typically what they would get in the first few days for the inflammation phase. And then right after day 5, I would actually start doing reciprocal inhibition. So remember, the goal therapeutically in the repair phase is to increase all 3 ranges of motion: active, passive, overpressure, and joint motion. Okay. So, and we had all the ball markers for that, right? We had active range of motion documented. We had overpressure documented. We had joint motion documented with the x-rays. We had joint motion documented with palpation, fixation, tenderness. See, we had all this documented and quantified. So I'm explaining to the new doctors because I'm trying to increase their conviction of what they're doing and why they're doing it. Okay. This is all part of a case analysis to increase my associate doctor's conviction. And we do this with all the new cases so they could see it, they could live it and experience it, not just see it in a video or read about it. That's what really drives it home. So typically at the end of day 5, we start working on a little more range of motion. And I typically would add reciprocal inhibition to like a modifier. We wouldn't do the full-time scale, it'd just be modified. And I'd have I trained a staff member how to do simple reciprocal inhibition for the neck and the low back. And that always feels great, by the way. Patients love reciprocal inhibition and they feel better and they move better immediately and they feel better immediately. Reciprocal inhibition. So I taught them how to do it in the back, how the neck, and then we do it modified. And then remember, you always have to continue doing what therapies you did if those bowel markers were still positive. So if the patient still had pain, we still did pain therapy. If the patient still had muscle spasms, we did muscle therapy. See, if the patient still had inflammation and tenderness, we still did inflammation tenderness therapy. See, so you always have to do those until those bowel markers clear up. And then you can add more. So it's not black and white. You do these bowel markers and then stop, and then you do these. It's not how it works. So now we want to start increasing their mobility with less pain. So, but we don't want to put force in there because they still don't have full range of motion with no pain. And that's just a general rule. I'm not going to put stress into any joint, the neck or back, unless they have at least full active range of motion with no pain. Because you don't have full activation with pain and you start doing exercises, you're going to irritate it. It's going to make it worse and it's going to take longer to get over if you haven't found that out yet. So that's kind of the demarcation to go into rehabilitation. Can they at least go through a certain range of motion with no pain with what I'm going to set them up with? So typically we started with reciprocal inhibition. And then typically they would still get the chiropractic adjustment. Remember, that helps with pain, helps with inflammation, helps with muscle spasms, helps with joint mobility. Chiropractic adjustment does a lot of things. And then I would typically continue including muscle stem or TENS unit. Now in my office at that particular time, I also had intersegmental roller tables. I did not use them in the beginning. Now we open offices and we don't use intersegmental roller tables for a lot of reasons. Number one, they're more costly. We're not big into expensive equipment. You don't need any expensive. It's absolutely crazy what's going on. People buying these soft wave therapy units for $30,000. I'm like, are you kidding me? And then they only buy one. You can never buy one because you just limited your practice. You could never have only one therapy. You just limited your practice, period. Henry Ford didn't have one station that puts, only one thing in. No, it was X amount of stations and all of them can do it. And they were finite. He didn't chase his ass. He didn't go in every damn circle chasing everything. That's why he became the multimillionaire. All the people that were chasing all the other car makers, that's what they were doing. They were chasing everything else. They were handmade and they were chasing everything else. You don't even know who they are. You never even heard of them before. Because they didn't make the big money. Henry Ford did. So anyway, these are all real concepts. Chiropractors violate all these things all the time. Then they don't do very well. Or they got to practice the rest of their life. So you go, at that time, I would include intersegmental traction. I didn't in day 1 through 4 because I found it irritated them. The joints were still too tender. Typically on day 5, they could handle it. And so I did 2 passive therapies, but it was simultaneous. I didn't do one and then the next. And remember, they're not timed. Passive therapies are not timed. They were on for 5 minutes. They were done simultaneously for 5 minutes, and that's it. Okay. They're not on there for 15, 20 minutes. There's no guidelines for that. There's no, you're not required to do that. Okay. Again, you can get deep in the woods limiting your practice in a lot of ways. And I was real careful not to do that. And also reproduce. I was paying a lot of attention to reproducibility. I didn't want to buy, a $30,000 machine. Number one, because you can't buy one. You need at least 3. And it's not reproducible. I open the next office. Well, that doctor now thinks he needs everything that I have. He now thinks he needs $30,000 soft wave therapies, or he won't be able to be successful. I can't have that. So we never had that. This expensive machines. It's like crazy what's going on. And that's just lack of confidence and knowledge in what you're doing. That's all that is. None of those are needed. So you go to, I would do that. So they would get, the muscle would help with pain and muscle spasm, intersegmental traction with passive motion with the motor units, the adjustment, mobility, all 3 ranges of motion, active, passive joint motion, nerve, gait theory. So you see all of these things are applying to the biomarkers. I'm explaining this to the associate doctors. Well, this is how it all, so it's real life now. This is real life stuff. Okay, so then they stay on their schedule. Because remember, it's not one visit and they're better. It's not how chiropractic works. Now, neurologically, patients can feel better quickly. But connective tissue doesn't work that way. Connective tissue is over time. So if you're only going to deal with the neurological component and symptoms, well, yeah, you could probably get away with a few, handful of adjustments, to be honest with you, if that's all you were going to take care of. And now you'd have permanency with any of the scar tissue. So we don't do that. We take care of both. So then we go, that continues on. They just stay on that treatment schedule until the next re-exam. And that's pretty much what they got to the next re-exam. And then next re-exam, which is the first re-exam. And then the first re-exam, I typically did motion studies. A lot of times I would do regular exam, x-rays on the initial, but the reason I like to do motion studies on the first re-exam is because I'm getting a more real vision of the orthokinematics, the biomechanics of the spine, because I'm not having as much intrinsic muscle spasms like when they're more painful in the beginning. So you won't get a true finding biomechanically. So I always liked retaking and I only took motion x-rays at the re-exam. That was one of the biomarkers that I liked using as just like range of motion, Kemp's test for amyloid. That was a biomarker. And that was a very, very important biomarker. Remember, that's the single most important biomarker, or how the bones are moving. Are they moving normal or abnormal? Period. That's always the end last biomarker. Because if they're not, everything comes back. Everything gets thrown into spinal degeneration, that whole pathological process. That 1 out of 5 people have in the United States called osteoarthritis, the #1 disability. That's how big it is. Okay, so they stayed on that schedule till the first re-exam. Now they're typically, the average patient's kind of starting to move into rehab a little bit. It depends. Do they have good range of motion and no pain? If at the first re-exam they had good range of motion, no pain, they're definitely starting resistance. Now, the resistance I typically used was TheraBands. And it's not exercise. And I can't say this enough. I am not going to try to get the patient to exercise. You want to lose a patient, tell them to exercise. I'm just looking for resistance. That's it. It's not mass that affects collagen. It's the signal that affects the laying down of collagen. The signal. So less mass and more repetitions is way better than mass when it comes to collagen synthesis and the laying down of collagen, the matrix of healing. So we're not having the patient stress. We're just having mild resistance with some repetition. That's it. That's all we're doing. And typically, it's real easy what we do. We only did neck and back. We didn't pay attention. We didn't do shoulders and wrist. We didn't go crazy and bog down the practice and try to do everything. We did we were the McDonald's. We had Cokes, French fries, shakes, and cheeseburgers, and that's what you get. If you want something else, you go somewhere else. And then we had high volume. So a lot of back and neck pain. That was very easy because everything was trained to it. All the systems, the therapies, the education, everything was trained to that. So we just did a ton of back and neck pain. But we knew marketing. We weren't starving, chasing everything left and right. That's why doctors chase, because they don't know how to get back pain and neck pain. The easiest, most effective patients there are. So they're typically chasing. That's why they buy machines. They think the machine's going to get them more business. No, that's not what happens. It just creates more expenses. So typically, that's the therapy they got for the first re-exam. We'd look at the motion. We make sure we confirm the patient education with the patient, with the biomarkers and the re-report. And then we would modify whatever therapy. So if we thought we could start some TheraBand, we could. You can also do some common ones as the Pinnacle cervical traction if you're dealing with that kind of an issue. That's only $150 per unit, and it doesn't take up any space. It hangs from the wall. So you're not talking about 6 feet out and 3 feet wide. So space is unbelievably effective. Cost is unbelievably effective. And the return on investment. That's an active therapy, by the way. That's not a passive therapy. That's not mechanical traction. They're actually working it. If you kind of know a little bit of, it's actually being worked. It's proactive is what's happening. So that's an active therapy. Or if there's even a TheraBall to affect the core muscles in the low back. See, so that's pretty cheap. These TheraBalls you can get again for $150 or less. I just kind of client buy a little wobble chair for $35. A great little, the wobble chair from Pinnacle is like $350. So we don't even buy those. So you can get a little $150 wobble to affect the core muscles. Or like he got the real cheap, really good little wobble stool, real small, nice and neat. I mean, it was just $35. He got it online. And that's an active therapy. That's not a passive therapy. See, that's it. I mean, that's all you need to cover all 3 phases of healing. Inflammation. Remember the goal of inflammation, decrease pain, inflammation. There's your therapies. Goal of the repair phase, increase active, passive, and joint motion. So we know all the biomarkers: active range of motion, passive overpressure, joint motion, palpation, fixation, tenderness. We got all the biomarkers. We've quantified them. We apply the therapy. Okay. So we add reciprocal inhibition to also increase with elasticity and mobility. All of this is quantified. Re-exam, we're measuring all these: active range of motion, joint motion, overpressure motion, palpation, fixation. All of these are being quantified and measured. And that establishes the need for care while you're doing what you're doing. And we already know what's going to happen physiologically with that patient, with not only neurologically, but physiologically with the connective tissue. We already know what's going to happen. The degree is the only variable, but we already know new collagen is being laid down. Now, how much do you want to try to impact that or affect that? That's up to you. If you don't want to fool with it and that's not part of your belief system, we did. Every patient that's affected to some degree. So every patient got to some degree, a little bit of passive resistance because we knew how this collagen thing works and the layer effect of the collagen. We're trying to limit that as much as possible. So it might not have been extensive, a young patient with no permanent problems. It could have been minor. But typically all we would do is put them in like the different resistance levels, the different colors of bands. And then we would just go, okay, well, what's the starting point? Well, we'd go into the band and go, we're doing 10 reps. We're doing 3 sets of 10 reps. That's what we're doing. So typically, and I would typically only do 2 planes of motion. If the other planes of motion were involved, I would do that. So it could have been forward, backward, left, or right, right? But we would start them at a very low level and go, can they do 10 reps, 3 sets of 10 reps? If they can, it's too low. You're starting too low. You come up to the next resistance until they can't do 10, 10, and 10. So they might go 10, 10, and 5. So fatigue setting. That's the starting point. Then they stay there. They'll stay there for maybe a week, 10 days, something like that, to where they can do 10, 10, 10. As soon as they can do 10, 10, 10, they're going to the next resistance level. Now they won't be able to do 10. Typically, even though it's a small increase, it might be just 3 pounds. I always like 3 pounds versus 5 pounds. I like to go real small. So now they can go, now you can go, now there might be 10, 10, 4. See, okay, well, they stay there. That's how we keep increasing, whether we do or don't increase them, and that's how. And that's the planes of motion we do. We only do it for the neck and back, that's it. And it's not strength. I'm more interested in repetition with mild resistance because it's the firing of the nerve that affects the collagen. We're not worried about the amplitude. We're not worried about bodybuilding Arnold Schwarzenegger. And the patient doesn't want to do that either. You want to lose a patient? Have them work out. I'm just worried about mild resistance with repetition. That's it. That's like when you do PNF, reciprocal inhibition. How much force do you need? Very little. You just need an activation of the nervous system. That's it. It's not force-based. It's, okay, apply a little pressure. Okay, hold right there. Hold. It's just mild force. That's all we're doing is activating the nerves. That's all. Same thing with rehab. We're just activating the nerves for collagen synthesis. We're not trying to build mass and lose a patient. And of course, all this is educated in. This is all educated in with the patient, with the science of the 3 phases in. But I'm paying attention to the conviction of the doctor. So he's seeing this. He's learned it. He's seen the videos, and he's experiencing it live. And the patient's getting better. The range of motion is increasing. The overpressure is getting better. The pain's going down. The tenderness is going down. All these things are shifting in real time. He's experiencing all this. That's what creates conviction, to where you end and all the biomarkers are normal. Hopefully the end goal is now all the biomarkers, symptoms, tenderness, neurological, orthopedic joint tests, active passive range of motion, and then resistance is good. What's the very last biomarker to clear up? The very last biomarker is always going to be intersegmental motion. That's what takes the most effort, is therapeutic protocol, right? Therapeutic protocol, the piezoelectric effect, repetitive over time. That's what changes connective tissue. You can't do it once. Now with a nerve impulse, you can. Boom, you can adjust somebody, they feel better immediately. That's the gate theory. So that can work fast, and it does a lot of times. Piezoelectric effect is not, it's connective tissue. That's repetition over time. And it needs repetition. I always say at least twice a week when you're in the remodel phase. And the analogy I use is lifting weights. Anybody that's lifting weights, go ahead and lift weights once a week and see what happens, what kind of development happens, how long it takes to develop. Not much at all. And over a long period of time. But if we're leasing them twice a week in the remodel phase, we'll see some good changes with some regular repetition twice a week over a relatively short period of time. Could be 2, 4, 6, 8 weeks. Again, it depends on the chronicity of the patient, the age of the patient, all those factors. And there you go. And then hopefully we got all the biomarkers. So symptoms are gone down, the tenderness is down, the nerves are good, the orthopedic tests are good, the muscle strength is good, the active range of motion is normal, the overpressure joint motion is normal. What's the last thing we're going to look for? Joint motion. How is the motor unit moving? How is that connective tissue now moving when it's been affected over time? The piezoelectric effect over time. Remember, what's the earliest amount of time you can see change on an x-ray? 3 months. So there has to be a minimum of 3 months before you take that x-ray. So 3 months later, I'm taking that motion x-ray. That's the single most important test, is the motion test. Now, you could pay attention to stationary if you want. I know chiropractic biophysics pays a lot of attention to stationary x-rays. I pay a lot of attention to motion x-rays because we live dynamic lives. That's why. Movement. How is the patient's spine moving? That tells the whole story. So all of these other symptoms can be totally gone. And if I have abnormal biomechanics at the end of 3 months, and I allow it to stay that way, I already know physiologically, mechanically what's going to happen. I already know how biomechanics, altered spinal biomechanics, affects nociception, pain signal, muscle, tendon, ligament, nerve, spasm. All of those are negative. All of them are negative when you have bad nociception due to pathologically altered spinal biomechanics. What's going to happen to that disc? They're in spinal degeneration. That's where they're in. How bad it is combined with how much movement they have in their life is going to determine the accelerant factor. So if they have not much bad movement, and they don't move a whole lot in life, they're not real active, it's not going to wear out as fast. They got a pretty bad spinal biomechanics, and they move a lot in life, they're real active. I think it's going to wear out fast. You have degeneration, and again, it's a complex. All of these tissues are affected. Disc, dehydration, ligament thickening, wearing out, space, joint facet hypertrophy, osteophytes, nociception abnormal, firing in the muscles, spasms, which causes anoxia, lack of circulation and oxygen, which alone causes pain and reflex spasm. It's that whole complex. Why? Because that motor unit is moving abnormally. So that's the ultimate goal. So that's what this 3 phases of healing is about. I already know the symptoms are going to clear up first, the frequency and intensity. Tenderness is going to clear up in active range of motion pretty fast. It won't clear up in overpressure motion as fast at all. Neurologically, we typically don't have problems with dermatome reflex issues. Orthopedic tests, the singular plane test, they'll clear up first. The tests that have 2 planes of motion, they'll clear up second. They'll take longer to clear those up. The tests that have 3 planes of motion with that lesion will take the longest to clear up. 3 planes of motion in overpressure. That's why KEMPs and foraminal compression are typically the last test to clear up. It's 3 planes of motion in overpressure. And in other words, you're stressing that anatomy the most before going into paraphysiological joint space. So we pay a lot of attention to those tests. You can have a lot of them to clear it up, but not those. And that's why we pay attention to do them right, because a lot of times they're not done correctly ergonomically. Then you go to the muscle strength. Muscle strength a lot of time can clear up unless it remains a problem. They continue to have problem in overpressure. You'll typically have grade 4 muscle weakness, and it'll heal that way permanently. And then you go into spinal degeneration. Where are they at now? Well, we already know it's going to get worse or not. And then you go into the vertebra. So what's the last motion to clear up? It's the motor unit. It's the x-rays 3 months later. That's the earliest biomarker. It's the last biomarker to clear up. And it's the earliest that you'll see changes. Now it has to be combined with physical medicine again, and then that's why I say at least twice a week in the remodel phase to affect the collagen synthesis in the matrix. So it's laying down and aligning in what you, the chiropractor, know as line of drive. And you already know that when you line of drive relative to bone, when you look at the femur and you look at the calcification and the stress lines on the femur relative to stress. That's exactly what's happening to the connective tissue in Davis's law. Exactly what's happening to wolf in bone. There you are. And now is it normal or abnormal? And of course, the whole goal is to get that motor unit back to normal as much as possible, as fast as possible. So if if it's not going good, we keep them on the treatment schedule. And then we can start cutting it down if possible. But remember, when do we know we're done with that patient? What's the definition of MMI? When you're at least in the repair phase of healing, you do 2 re-exams and there's no improvement. You're done. You can beat the dead dog with a stick. It doesn't matter. It's done. It's over. So that's how we know when we're done with that patient. If they're continually getting better, if those motor units are getting better, guess what? We're treating them. We're going to keep treating them until if they keep getting better, we're going to keep treating them until they're normal. We go into 2 re-exams in the repair phase. I compare 2 x-rays. I don't see any change in 2 x-rays in the remodel phase. It's over. They're at MMI. That's permanent. Now they just go into palliative care. Now they go into the lifestyle patient education. And all of this is what's all trained into the associate doctor. This is how you increase their conviction. They're seeing it. They're experiencing it from day 1 to day 2 to the week 3 to week 4 to the 3rd month. We're looking at the biomarkers. They're all changing. We already know what's going to clear up 1st, 2nd, and 3rd. We already know. And we're just following it through, applying the proper protocols relative to the biomarkers, relative to the timing of the 3 phases of healing, making it affordable. It's been well educated into the patient. The goal is to get all those back to normal or as much as possible until they reach MMI. There you go. That's how you install conviction in your associate doctor. They don't have a clue what I just said. Coming out of school, they don't have a clue what I just said. They couldn't even explain what I just said, but yet they have their degrees. So you're the one, the head doctor, you're the one that's got to teach them this. You got to not only show them a video, have them read the paper. No, that's not just going to increase conviction. They can experience it. And that's when the doctor goes, oh, I see why they need 30 visits or 40 visits instead of their timid 6 visits. And then now, so that's the visit component. That's how you handle the visit component with the doctor to have them overcome that problem. Now, how do you overcome the money problem? Because everybody's got a money problem to some degree. Well, you just break it down. We just take whatever that costs and you just keep breaking it down. Really, if the doctor's not comfortable, you just keep breaking it down to their comfort level. When they're comfortable and good at that, getting people to prepay, then just increase it a little bit and then do it again. When they're comfortable and they got confidence with that, then just increase it. That's how you get doctors who have low conviction, low confrontation, to be dynamo chiropractors and fair. They give a fair price. In other words, it doesn't matter if it costs $3,000 because we're not going to ask for $3,000 up front. We're going to make it affordable. We're going to make sure the biweekly payment's affordable. And then we know what we're trying to do clinically. That's conviction. That's where you need to take your associate doctors.